Hi, I'm Dr. Bill Gradishar, Professor of Medicine at Northwestern University, and I'm pleased to be participating in this Yerbba YouTube session on lobular carcinoma. So when we think of breast cancer, we often think of it as a single entity, and we know that there are, number one, many different kinds of breast cancer. Two are the primary ones. One is ductal carcinoma, and the other is lobular carcinoma. And they account for in excess of 90% of all breast cancers. And then there's some, unusual or strange breast cancers that account for, very tiny fractions of all breast cancer. Lobular carcinoma accounts for about 10 to 15% of all breast cancers. And I can sort of cut to the chase. At the present time, we approach patients with lobular carcinoma very much the same as we approach patients with ductal carcinoma. So there isn't a particular pathway or a particular treatment that we use in ductal that we don't use in lobular or vice versa. But there are differences between the two kinds of breast cancer that can make it challenging both for the treatment, diagnosis, and other aspects of care of patients with lobular carcinoma. So when patients are initially being evaluated for the possibility of breast cancer, a biopsy is done, and that helps us determine what the subtype of breast cancer is. And they base that on the histology, or what it looks like under the microscope. And I guess one of the things that we should, even before we get to that, what they see under the microscope, is when you think about normal breast anatomy in a very simplistic way, and I'll relate this to one of your favorite vegetables, like broccoli. So broccoli, you can see the hard stems leading up to the green part of the vegetable, and the stems that lead up to it are the ducts, and the green fronds of broccoli could be viewed as the lobules. And most breast cancers develop in the ducts, so about 85%, whereas a small fraction develop in the fronds of the broccoli. Most of breast cancers are hormone receptor positive, ductal or lobular. Lobular is even a little bit more frequently hormone receptor positive than ductal carcinoma, and less frequently HER2 positive. The other thing that one should also keep in mind is in any given breast cancer, it's possible that you can have both ductal and lobular. So sometimes a cancer is not pure ductal or pure lobular. It can be a mix.
Diagnosed with breast cancer? Meet Yerbba, your guide to personalized treatment options. Each option is specifically tailored to the unique characteristics of your tumor. Sign up today at Yerbba.com to take control of your breast cancer journey.
The challenge is when you're making the diagnosis, oftentimes when a patient first comes to the attention of their caregiver, is they may get a mammogram, and there may be something that's ill-defined, and that may prompt further evaluation. In patients with a lobular carcinoma compared to a ductal carcinoma, we sometimes can see a pretty well demarcated area of concern. With a ductal carcinoma, it can sometimes be much more vague, both on a clinical exam as well as on imaging, when you have a lobular carcinoma you're dealing with. So that in of itself is challenging, and not infrequently, the extent of the disease is often underestimated based on the imaging or clinical exam. When you look at it under the microscope, what you see are a very linear orientation, sometimes not we call it Indian row, like they're lined up. The tumor cells can line up under the microscope, and the pathologist will make that comment that they have that specific orientation, meaning the cells to one another. And they can also do special stains that help determine whether it's a lobular or ductal carcinoma. So on clinical exam, as opposed to a ductal carcinoma where a lump may be more easily detected or appreciated, lobular carcinomas at best may have something that's vague that you're feeling, or nothing at all. There may simply be an abnormality that's suggested on an imaging study such as a mammogram. So you have to have a high level of suspicion, you have to follow through, and ultimately it's the biopsy that confirms the diagnosis. And once the diagnosis is made, you go through the same thought process as a ductal carcinoma. You have to decide, is the patient somebody who can go immediately to surgery, or does the patient need preoperative chemotherapy if it's a bigger tumor? You have to look at the markers. But assuming the patient goes to surgery, you assess the size of the tumor, you assess the nodal status in the armpit, and that's often done with the sentinel node biopsy. You then may make a determination based on special molecular tests. Does the patient need chemotherapy or not, based on, say, oncotype or mammaprint? These are molecular tests. And since most of these patients are hormone receptor positive with early stage disease, at a minimum, they're all going to get anti-hormone therapy. So very much the same approach as we would see in patients with the more common ductal carcinoma. What's unique about lobular carcinoma is that patients, if they were to develop recurrent disease, it can develop sometimes in odd spots. So as an example, sometimes we'll see patients that have little tumor implants on their ovaries or on their GI tract, on the outside of the GI tract, or they can develop an effusion, what we call fluid accumulation in the lung or belly, and that can be from small tumor deposits of lobular cancer that, for whatever reason, tend to seed in those specific areas, which is unique compared to ductal carcinoma, where that would not be as common. And then, of course, to confirm that there is a problem or there is metastatic disease, you have to do a biopsy demonstrating that, again, you have a recurrence, it is still lobular, and that the markers remain the same. And the approach to lobular carcinoma that is metastasized, so somebody with advanced disease, is again the very same thought process we use for any more common breast cancer like ductal. You look at the markers, you may do special molecular testing to determine if any mutations are present, and then make a treatment plan based on those factors. The important point to understand is, although there's a great deal of research going on in trying to define the biology of lobular, and as a result, can we develop specific therapies for lobular cancer? At present, the treatment for lobular cancer is identical to what we do with ductal carcinoma. So we don't have distinct pathways or different treatments for ductal versus lobular. So hormone-sensitive breast cancer, which most ductal, most lobular are, does not respond as well to chemotherapy. And even looking at lobular specifically, lobular carcinomas are less likely to respond to chemotherapy perhaps than ductal carcinomas. So again, our enthusiasm for using chemotherapy may be a little bit less, and if a patient is hormone receptor positive, we tend to think of endocrine or anti-hormone therapy as a better choice for many patients. Now, of course, there may be situations where chemotherapy is recommended, and there are specific reasons why we would do that, but we have to keep in mind when we're talking to patients that the level of activity of chemotherapy in lobular cancer is somewhat less. Similarly, certain hormone therapies, or anti-hormone therapies more specifically, may not work as well in lobular cancers as they do in ductal. We tend to use aromatase inhibitors more than we might use tamoxifen in patients with lobular carcinomas. But again, there isn't a specific therapy that is unique to lobular that we don't use somewhere else. It's just there are small differences. And of course, we're hopeful as we go forward, we'll have a better understanding of the biology of the disease, and as a result, develop therapies that are unique to lobular carcinoma. At present, we do not have those. So this brings this session on lobular carcinoma to a close. If you'd like to learn more about your own clinical situations and therapeutic options and the differences between different therapies that might be available, you can go to Yerbba.com. It's important to note that lobular carcinoma is still treated the same as ductal carcinoma, which is the more common type of breast cancer. But to appreciate the differences between these types of breast cancer, you can get more information at Yerbba.com. I look forward to talking to you again about another topic related to breast cancer. I hope you enjoyed this session. Thank you.